Thank you very much, Dr. Kukita, and good morning, dear colleagues and friends. I would like to thank also the World Veterinary Association and the World Medical Association for inviting me here today. It's a great pleasure and a great honor to be here in Japan. And it's also a fantastic opportunity for me to be back in Japan because I had the privilege of spending part of my PhD program at Tokyo University a long, long time ago, in 1998. I was living in Iidabashi in Tokyo for 6 months, and I had a fantastic time of my life. And I have to say that Japan and the Japanese culture has been on my mind ever since, and so Japan has a very, very special place in my heart. So really great to be back here. Good. So I have been asked to talk about antimicrobial resistance, the threat, the drivers, and the solutions. And before I start my talk, I should actually already also like to congratulate you because you have provided some of the solutions. And I'd like to congratulate you with your National Action Plan that you published in April this year. I had read the plan. I was actually in Sendai when the plan was launched in April earlier this year, and I have been very impressed by what you have done. So my sincere congratulations with your plan. So let me start first with the threat. My talk is divided in 3 parts, as you can imagine: the threat, the drivers, and the solutions. And I'd like to start with a figure that was published in one of Jim O'Neill's reports. So Jim O'Neill is a famous economist from Goldman Sachs, and he was asked by David Cameron in 2014 to write a number of reports on the AMR threat. And I think that the first report was probably the most threatening report because he provided some figures in that report on the attributable deaths to AMR in 2015, provided that we wouldn't do anything. And so Jim O'Neill's team calculated that you could expect 10 million people dying in 2015 of AMR if we wouldn't do anything. And that, according to this group, is more than cancer. So that was something that was very alarming and was worldwide covered in the press. But in the same report, he also looked at where would people be dying of AMR. And actually, the biggest threat is in Asia. It's in this part of the world where we are today. And he calculated that 4.7 million people could die in 2050 of AMR. And the second threat is in Africa. And he calculated around 4.1 million people dying in 2050. So these are really threatening figures. I'm going to show you just one slide. This is not published, but I think it's interesting to look at this data. Because again, it's from this part of the world, and it's data on a surveillance network of neonatal infection in the Delhi area, looking at antimicrobial resistance among Klebsiella pneumoniae, Acinetobacter baumannii, E. coli, Staph aureus, and also Enterococcus. Resistance to several antibiotics. And if you look at this data, this is really, really very shocking. If you look, for instance, at Klebsiella pneumoniae, in this surveillance, nearly 80% of the strains are multi-drug resistant. That is amazing. If you look at Acinetobacter baumannii, more than 90% of these strains are multi-drug resistant. So how do you treat these babies with infections? If you look at E. coli, over 50% of them are multi-drug resistant. How do you treat these babies with these kind of infections? MRSA is also high, 31%, and VRE, vancomycin-resistant enterococcus, are over 40%. So to me, this is some of the worst data that I've ever seen on resistance in humans. That's for hospitals. Let me show you some data for the community. An interesting study looking at ESBL carriage rates in the community, showing that particularly the problem has been increasing again in Asia. So these are data for Southeast Asia, where you can see that around 70% of community isolates produce ESBLs. That is very, very high. It's much higher than the Eastern Mediterranean area. It's much higher than Europe and North America. So clearly, there's a big problem, particularly in Asia, about antimicrobial resistance. And this is certainly due, and we can come back to this, to high-level environmental contamination. And that's the kind of thing that, of course, that is a big threat to the future. Flooding, people bathing in contaminated water, or sewage that finds its way to the rivers. So these are really one of the main reasons why we have such a big threat for the future on antimicrobial resistance. And then the last slide I wanted to show about the threat is this one. The presence of carbapenemases in animals and in the environment. So carbapenemases are enzymes that destroy most antibiotics, including the carbapenems, and those antibiotics we do not want to lose because they are the most important antibiotics for treatment of infections in hospitals. Well, we found, and this is quite amazing, we found these carbapenemases now in animals such as cattle in this study, broilers and swine. We found them in horses and cats and also in different types of other animals. Eventually, we will also find them in food, and that could have a big impact on trade if indeed food is contaminated with carbapenemase-producing organisms. So that is a big, big concern. When I started microbiology in the 1980s, when I was actually doing part of my research in Tokyo, I never thought that I would end my career showing this slide or such a slide. It's really amazing. So what are the drivers of resistance? Well, obviously, the first driver you think of is antimicrobial consumption. And so, this is one slide I want to show you to convince that antibiotic use is the single most important driver for emergence of macrolide resistance and streptococci. This is a study that we did more than 10 years back. And you know, this was the first ever double-blind, placebo-controlled, randomized controlled trial of exposing volunteers to either a placebo or a macrolide. And these volunteers were medical students at our Faculty of Medicine in Antwerp. Nobody had ever done such a placebo-controlled, double-blind, randomized controlled trial. It had never been done. And so people were always saying, where is your evidence that antibiotic use drives resistance? So this is what we did this study. So we exposed these medical students to macrolides, and we choose clarithromycin and azithromycin and compare this to a placebo. What we found, first of all, was that around 30% of the streptococci in your throat, about 30% of streptococci in your throat are resistant to macrolides. Now, we are a relatively high macrolide consuming country, but I think Japan is even higher in terms of macrolide consumption. So if I would be calculating your throat, if you are from Japan, and if I would calculate your throat, I am pretty sure that in your throat, maybe 40 or 50% of your streptococci are resistant to macrolides, so even higher than in Belgium. So when we expose these volunteers to either clarithromycin or azithromycin, we see after 1 day of exposure, massive selection of resistance. And most of the streptococci in the throat are resistant to macrolides. That's amazing, how quickly you select for resistance. And actually, we decided to follow these volunteers for 6 months. And after 6 months, we were still not back at the baseline. So if you treat somebody with antibiotics or you give somebody antibiotics, your resistance will stay for about 1 year. And that is an amazing figure. That's one major driver of resistance, but there's another driver, and that is the pandemic spread of clones, genes, and plasmids. And I'll give you a few examples. And that's another amazing story. And I give you a few of these. So this is a pandemic spread of a combination of a unique clone of E. coli, an SD131, with a CTXM15 ESBL enzyme. Those two, CTXM15 ESBL enzyme and SD131 clone of E. coli, have found themselves. So it's something that emerged since 2008 in 3 continents and have spread over the last 10 years. So it's basically a pandemic spread of one particular epidemic clone in combination with a plasmid or a gene with this CTXM15. Isn't that amazing? It's just like flu. In flu, you have a pandemic spread of one particular flu strain over a period of 1 to 2 winter months. Well, with these resistant bacteria, it's the same. It's one particular genetic clone of E. coli that spread not over 1 to 2 years, but over 10 to 20 years. But it's the same pandemic event. It's exactly the same thing. And this is a review of recently published. Where you find this SD131, you find it all over the world. Anywhere you look, you will find this particular clone. Now I'm going to tell you 3 stories of carbapenemases, the most important carbapenemases. And these are KPCs, NDM, and OXA48. 3 different stories of pandemic spread of carbapenemases. The first story is the story of KPC, so that's a carbapenemase, producing Klebsiella pneumoniae. Why has this KPC spread globally, starting with the east coast of the United States to Central and South America, some of the European countries like Italy, Greece, and Poland, and again some of the Asian countries? Why has this spread so successfully? Well, this is because these two again have found each other. A carbapenemase called KPC and an SD258 Klebsiella pneumoniae clone. A unique event. They have spread over a period of 10, 15 years. Amazing. We don't know exactly why this clone is so successful. There are some theories about it, but we don't know exactly why. What we do know is how did this clone actually emerge? And it's probably a recombination of 2 SD types, an SD11 and an SD442. And the SD11 has a special integrative conjugative element, and the SD442 has a special capsular polysaccharide. And this capsular polysaccharide may be responsible for very good adherence to surfaces, to walls, to bed linen, to anything you like, just like MRSA. It's the same kind of behavior in hospitals. So this is a unique event. The second story is a story of NDM, the New Delhi metallocarbapenemase. Now this is a story that started not at the east coast of the United States, but probably in India, and then spread over other countries in Asia, and eventually you can find them all over the world. This is a different story. This is a story of a gene that can jump over from plasmids to plasmid and spread globally. So this is a second really global event. And then the third story is a story of the OXA48 carbapenemase. Again, a different story, probably also starting in this part of the world, perhaps in India, but it could also have started in Turkey and in some other Mediterranean countries and spread all over there. But again, you find OXA48 all over the world. And why do you find OXA48 all over the world? Because it's due to a very successful spread of one particular plasmid, P-OXA48A. So you can see 3 different carbapenemases, each of them spread differently. Why is that so? Well, I used to say because gram-negative bacteria, those are the bacteria that live in your and in my gut, such as E. coli, Klebsiella, and other gram-negative bacteria. I used to say they like to have sex in your gut, and they like to have exchange of genetic material. So they form these kind of 6 pili, and through these pili, they can easily transfer their genes and their plasmids. That makes it very unique. And you can see already the One Health challenge, because the same gram-negative bacteria are also present in the gut of animals. And we will share some of these strains, and we'll share some of the genes, and we will share some of these plasmids. And therefore, you have this spread, because you found them in households, and they will share them with their pets. You'll find them in animals, food-producing animals. Therefore, you find them in food, and you will find them also in the environment, like in India, for instance. So what are the solutions? That's the third and last part of my presentation. Well, I have a slide that I always use when I talk about solutions, and it's also the hallmark of your plan, of your Japanese plan. It's surveillance. And I love to use this quote from Lord Kelvin. If you cannot measure it, you cannot improve it. The first thing you need to do, and you've done this already in Japan, is to measure. What is my situation? How bad or how good is it? And so I've spent 15 years of my life measuring antibiotic consumption in the world. And I started doing this 15 years back with money from the European Commission, looking at antibiotic consumption in outpatients in Europe. So these are data we published Lancet Infectious Diseases in 2014, looking at total antibiotic use in numbers of DDDs per 1,000 inhabitants per day in 42 countries. And you can see that in that study, Turkey was the highest consuming country. And the lowest, and I'm sure one of the speakers or the next speaker will be very pleased to hear that, the lowest was the Netherlands. So where is Japan? Well, in this report is a very nice figure on page 7 on antibiotic consumption in Japan in DIDs. Japan is at 15.8 DDDs per 1,000 inhabitants per day. So that's not too bad. I mean, you behave a bit like a, let's say, Northern European country. Which is pretty good. The US is, by the way, a lot higher. So Japan is around here, around 16 DIDs. So that's very important data, because this is the kind of data that politicians understand. If I talk to ministers in Europe and I tell them about ESBLs and carbapenomases, I have them for about 1 or 2 minutes, and then they start, thinking about other things because they can't understand any of these things. But when I show them consumption data, that's something that they understand and something that shocks them. Because, behind consumption data, there's also expenditures data. There's a cost here also for social welfare. So politicians understand this much better than resistance data. And this triggers a lot of action plans. And that's why governments in many countries in Europe have set targets. And so we, for instance, in Belgium set targets. We've expressed this in packages per 1,000 inhabitants per day, and that's where we want to be in 2020, and that's where we want to be in 2025. The Swedes, actually, they have shown us how we should do it in Europe. They already started with a target in 2011, and said in 2011, the Swedish government decided we want to be in 2014 at 250 prescriptions per 1,000 inhabitants per year, a different way of measuring it. And I can tell you the Swedes are now at 320. They're very close, so my hat off to the Swedes. Norway, this is the beauty of Europe. If the Swedes would do something, then you can be sure the Norwegians will also do that. That's Europe. And then this is England, and this is Turkey. So Turkey, when the Turkish government found out about our Lancet Infectious Diseases study that was going to be in press, they didn't wait for the publication in the Lancet Infectious Diseases. The Turkish government already said, we are going to set a target, and the target is going to be 35 DIDs. It's not that ambitious, but at least it's a target. So we had the privilege of doing last year a global point prevalence survey. What does that mean? Well, we decided last year that we would, on one particular day, decide or at least measure antibiotic consumption in all hospitals all over the world who want to participate. So the principle is, one particular day at 8 o'clock in the morning, Who are your patients in your hospitals who receive an antibiotic? Why do they receive an antibiotic? What is the duration of treatment? What is the dose? What is the indication, etc.? And so for this global point prevalence survey, we had also a very good collaboration with somebody in Sendai, Dr. Gu, and it's been really wonderful to collaborate with him and his team, and 13 Japanese hospitals participated. And I think it's the first time that we did this kind of study together with Japanese hospitals. So I have 2 slides about surgical prophylaxis, because I think that's where you need to focus in Japan. So as you know, when you admitted to a hospital for surgery, you may get antibiotics for surgical prophylaxis. And all the guidelines, from the very north of the North Pole to the very south of the South Pole, all the guidelines would tell you maximum 1 day surgical prophylaxis. Well, in most Japanese hospitals, it's in red and it's more than 1 day. So you need to cut down for surgical prophylaxis. That's one thing. The second thing is we looked at Japanese hospitals. What are you actually giving for surgical prophylaxis? Well, a lot of cephalosporids. 2nd and 3rd generation cephalosporins are in the top 10, and that's not good. It should basically be cefazolin, because that is the best one for surgical prophylaxis. So I think that's where you need to focus on, for instance, in hospitals. So that's why governments again set targets, like in Scotland for surgical prophylaxis, like in England, like in the US, and also China has set a target in terms of antibiotic use in general hospitals, and they would like to be less than 40 DDDs per 100 patient days. So also the Chinese government is setting a target. So I finish with something else that could be done based on the trends of MRSA, where you can see that in many countries it's still high and increased, but in 2 countries it decreased dramatically. In France and in the United Kingdom, MRSA has decreased dramatically. And in fact, in most EU countries, MRSA have decreased. And that has nothing to do, I think, with antibiotic use or reduction of selection pressure. I think it's mainly due to infection control, hand washing. Many countries in the European Union have national campaigns for hand washing. So that's very important. So I'm finished now with just 1 slide on the One Health concept. This is a very nice figure showing that the solutions for One Health are going to be daunting, because of the complexity and the interactions between animals, between the environment and water, and then the link between humans is going to be very complicated. But just to finish, we are finishing a remarkable year. 2016 has been an unprecedented year for AMR and for the support. And I give you 2 examples. The G7, the G20 summit in Hangzhou discussed the AMR and made a very strong statement that AMR should be addressed. You mentioned the G7 health ministers in Kobe also made a statement about AMR, and they strongly recommended to set up clinical trial networks globally to study AMR and to do interventions. And then, of course, absolutely unique, the General Assembly of the United Nations in September 2016 also discussed AMR. And in fact, it's just the first time ever that a One Health concept was discussed at the General Assembly of the United Nations. So my final slide, I think 2016 we had the most significant attention ever from senior global political leadership. But I only hope that it will eventually lead to some really big initiatives worldwide. And I'm a bit concerned because 2 important politicians will have disappeared in 2017, like David Cameron and Barack Obama. And both of them were personally very much involved in driving the AMR agenda. Let's hope it will continue in 2017. So thank you very much for your attention.